Hello and welcome to COVID-19 webinar number 19 from New York Medical College and the Touro University System. My name is Edward Halprin. I'll be your host. And here we are again in year 3 of our webinars. We began these programs in January of 2020 and we're up to our 19th session. I think I have used every clever witticism I can think of to begin these sessions, making interminable jokes about how long we've been on the air and how many of them we've done. So I'm thinking that we're going to adopt the policy that was followed by Louis Rukeyser of Wall Street Week. Remember that public television show in which he would try to explain the economy to you and give you stock tips and tell you whether the Dow Jones went up or down? That show was on television for so long that they used to, by the end, dispense with the long welcomes. They used to just look at the camera and say, "Hello, this is Louis Rukeyser. Welcome back." So I guess we've been doing these COVID-19 webinars long enough that I can start saying, "Hello, this is Edward Halprin. Welcome back." For our webinar today, we're going to bookend our presentations with 2 people who spoke to us at our very first webinar in January 2020. When we first were wondering whether this was going to have much of an impact on the United States, you were addressed by the Public Health Commissioner of Westchester County, New York, Dr. Sherleta Amler. It turned out that New Rochelle became the epicenter of the pandemic, and Dr. Amler was up to her eyes in alligators, as we'd say back home in the South, and she is going to join us to speak with us today and tell us, after the last 2.5 years of being a public health commissioner, what have I learned? And we're going to have Dr. Robert Amler be our cleanup hitter today for our speaker, because this turns out to be the 3rd year where I've invited Dr. Amler to talk to all you moms and dads and grandmas and grandpas and family members to say, can you send the kids to summer camp? What about sleepaway camp versus day camp? And can you plan that summer vacation based on how things are going with the pandemic? So Robert Amler's back to give us some advice. Now, in between the 2 Amlers, we've got a couple of speakers you have not met before. I was struck by an article in the New York Times about the enormous disparities in vaccination rates in Ocean County, New Jersey. And so I've invited Mr. Daniel Regenier from the Ocean County Health Department in New Jersey to talk to us about the disparities in vaccination rates and what he's learned is working and what's not working. With all of the questions that have been coming in about should I get a 4th shot or not, I've invited the chairman of the Department of Family Medicine at New York Medical College, Dr. Laurie Solomon, to speak to you from the standpoint of a primary care physician. With all this conflicting data about whether I should get a 4th shot or not, what is she telling her patients and what does she advise you? And our other new speaker is a professor at the Touro University School of Pharmacy in Manhattan, Dr. Michael Liu. I've asked him to speak to you about the interesting problem of, well, they recommended that I get therapy for COVID-19, but the pharmacy says they can't get their hands on any. What's happened in the supply chain for pharmaceuticals in this pandemic? What can we learn from it? And what might we learn to do better? So we've got a great group of 5 speakers for you. Now, remember, if you have any questions for any of our panelists, please type your questions in the Q&A function on the bottom or the top of your screen, depending on the version of Zoom you have, and we'll get to as many of them as we can in the Q&A part of our program, which will be hosted by the president of Touro University, Dr. Alan Kadish. Now, I will be appearing periodically in between the speakers to tell you how to get your CME credit and where to text in that secret code to sign up for the CME credit and fill out your satisfaction questionnaire. I'll also be appearing in between the speakers to make a shameless pitch for some of you to consider making a charitable donation to New York Medical College to support these webinars, and also to tell you about our course offerings in medical ethics for those of you who are interested. So this is Edward Halpern. Welcome back, and let's get started with our program.
Hi, I'm Dr. Sherleta Amler, Commissioner of Health for Westchester County. I have no conflicts to disclose. Tuesday morning, March 3rd, 2020, 3 a.m., I got a call from New York State Department of Health. Woke me up in the middle of the night. A call at 3 a.m. from the Department of Health is never a good thing, especially when the call is coming from your boss at the State Health Department. The conversation went something like this. Just letting you know that Westchester has the first case of COVID-19 outside of New York City. Please have all your nurses that you need and any support staff that you need and their PPE and vehicles and whatever other equipment you're going to need to start working on the contacts for this case. I need you to have everything there by 8 a.m. this morning. And I, as you can imagine, never got back to sleep that night and for many nights to come. So when all this went down, as you can imagine, the public was very, very frightened, especially when all this started hitting the paper. And they looked to public health officials for answers that we did not have. We didn't have that because this was a new virus with new health effects. And in March of 2020, no one had the answers, not even the CDC. There were many things that we wish we knew, but we didn't. We didn't know what was the genetic profile of the virus. We didn't know the natural history of this particular disease. We weren't even sure how it was transmitted. Were there vectors involved? Of the drugs that we had available to us, would any of them work as a treatment for this particular virus? How long was it going to take, or would we even be able to develop a vaccine? And what protocols should be in place? These were all things that, unfortunately we worried very much about, but we had no answers at that time. So since there were no answers, we went back to the public health basics that we've used in the past through other outbreaks. And we started by creating a case definition. We worked to identify cases and their contacts. We worked to identify the duration of quarantine and isolation. We began to communicate what we did know, but more importantly, a lot of times what we didn't know, to healthcare providers, the media, and the public. And as we learned information, we began to use it to improve how we manage the situation and improve our response. In other words, we try to overcome the situation. This has been the largest public health response in my generation. To date, Westchester County Department of Health has investigated more than 430,000 COVID positive cases and identified more than 1 million contacts. At first, we were only making rapid calls, primarily to inform people of their positive COVID test results. So the calls went something like this. You've tested positive for COVID-19, and we need you to isolate yourself from others for the next 14 days. Please contact the people you've been around recently and let them know. Later, we started issuing legal commissioners' isolation orders to positive individuals and began interviewing for their contacts. Quarantine orders were issued to the contacts. As the pandemic progressed, we expanded our data collection beyond just asking about their contacts to include demographics, symptom history and onset. What was their living situation? Where did they go to school, or what type of work did they do? Any recent travel, or what have been their recent activities? We also did a more in-depth interview on random samples to try to collect even more information. In addition, we work very closely with our local schools, both public and private, to assist them in reducing the spread of COVID and to aid them in identifying COVID positive cases and their contacts within their facilities. The goal was to keep the schools open so that children could continue their education during the pandemic. Westchester County Department of Health worked with 44 school districts, 2 BOCES, 9 private schools, and over the course of the pandemic, we have done performed more than 310,000 samples, of which 5,545 were positive. The Westchester County Department of Health has also been operating a COVID testing site at our county center in White Plains since Westchester Medical Center closed its vaccine operation at the site. Approximately 3,290 samples have been collected at the county center, and 680 of these samples tested positive. In addition, Westchester County Department of Health has been operating vaccines clinics in both our White Plains and Yonkers clinic sites. This is in addition to the efforts of local hospitals, medical providers, and pharmacies. We have also held vaccine pop-up clinics at local schools and community locations throughout the county. We have sent medical providers into the homes of homebound individuals who are medically unable to get to a provider to provide in-home COVID vaccines. And in total, Westchester County Department of Health has provided more than 77,000 doses of vaccines to our residents. As the pandemic has evolved, we have had to monitor the changes, such as the infection rate, hospitalization numbers, and the numbers of death. And when it came to deaths, we also wanted to know what were the age groups of people who died from COVID and what underlying medical conditions did they have. All of this was done to help us modify our response. We have provided guidance regarding the interpretation of the constantly changing federal and state regulations, executive orders, and New York State guidance documents to the media, the public, professional groups, school administrators, as well as to gyms, swimming pool operators, summer camp administrators, restaurant owners, and to congregate care facilities, just to name a few. And while all of this was occurring, we managed to continue our core public health functions. We continued to monitor for 84 communicable diseases and to work to prevent their spread. We continued our community health clinics, treating TB, STIs, and providing immunizations and WIC. We continued our environmental health responsibilities, such as inspecting restaurants, monitoring water systems, inspecting summer camps, swimming pools, investigating sewage and other public health complaints, and investigating oil and water spills. We continue to provide public health promotion activities, education, and communication on a wide variety of other public health issues beyond COVID-19. We continue to ensure that medically at-risk children less than 3 years of age received early intervention services, and children 3 to 5 years old at risk received their preschool services, just to list a few activities. What do I tell a young person about a career in public health? For me, the best part is that no 2 days are ever the same. I always think I know how my day is going to play out, but then suddenly I get a call and there's measles in a community, or a case of meningitis, or an outbreak of hepatitis linked to a local restaurant, or a congregate living facility with flu or norovirus, or a traveler visiting our country and our county who has multi-drug resistant TB, or Legionnaire's disease linked to a cooling tower. There's always new challenges and new emerging diseases, such as H1N1, Ebola, Zika, and COVID-19, just to name a few. And suddenly my focus has to change to the situation at hand. This career has allowed me and my staff to promote health and prevent disease for 1 million people, the million residents of Westchester County. The basic tenet of public health is that it's always better to prevent disease than have to treat disease later. The role of public health is, and really the role of all medicine and all medical providers, is to enable people not just to live longer, but to live longer, healthier, and better lives. Helping people continue to do the things they love well into retirement, and not just to survive to old age, but to actually thrive in older age. In closing, I love my job. After 30 plus years in public health, I feel honored to serve the residents of Westchester. I wouldn't change a thing. I love my job. So if public health interests you, I would say go for it. I'm Dr. Sherleta Amler, Commissioner of Health, Westchester County. Thank you.
Hi, this is your host, Edward Halpern, back to tell you how to get your continuing medical education credit for those of you desirous of the same. As always, we've got 3 ways to get your CME credit. You can text the code 94EARL, all in capitals, 94EARL. Text that to 828-295-1144, and you'll get a text message back walking you through how to fill out your satisfaction questionnaire with this webinar and how to get your CME credit. Or if you don't want to do that, you can go to the website, www.eeds.com, and click the sign-in button, enter the code, and it will once again walk you through the process of filling out the questionnaire and getting your credit. And the third option is for those of you with iPads or cell phones with those QR readers. You can hold them up and point them at that symbol, and your phone will vibrate, and then it will walk you through the process again of doing the questionnaire and filling out the paperwork to get your CME credit. Whatever you choose to do, go ahead and do it, because these are all going to expire by noon on May 23rd. So don't forget to go ahead and get your CME credit. Remember, if you have a question for our panelists, type it in the Q&A box. And there always are some of you, every one of these webinars, whose question is, how do I get my CME credit? When I just told you how to get your CME credit. So this time, maybe take a screenshot or get your cell phone out and take a picture of the screen, or write the number and the code down. But go ahead and save the information so you'll know how to get your CME credit. And now let's go back to our panelists.
Good afternoon, all. My name is Dan Reichney. I'm the Health Officer and Director with the Ocean County Health Department, here to present some information related to our COVID response of work that we've been working very diligently on for the past 2 years plus with this. Our approach to disparities in the vaccination rates, and really looking at the one size does not fit all, and trying to move forward as we continue with our vaccination efforts, which continues to this day as we move forward. For the purpose of this presentation, I do not have any conflicts to disclose. Just a little bit about Ocean County in general. We have a population of about 625,000 residents year-round. That population doubles in the summertime. We are a high destination point for many tourists from North Jersey, from Philadelphia, as well as out of the state and the region as well. We have 33 municipalities that are covered by 2 local health departments. We cover 27 of those 33 towns, and Long Beach Island Health Department covers 6. We are the 2nd largest county geographically, which also provides some of the challenges related to some of the vaccination and just the demographics in general, looking at our vaccination strategy, which I'll talk about in a little bit as well. We're also one of the largest growing populations in the state. We have a very large senior population in the country. We have almost 100 senior communities, And just looking at the epidemiology of COVID from the beginning was certainly one of the major concerns that we had with our very high risk population here within Ocean County. And you would think it wouldn't be possible, but we are also home to one of the youngest towns in Lakewood, population of about 120,000, almost 50% of that population is under the age of 18. We're a very diverse population with our geography. We have a very large Orthodox Jewish population, which we work very closely with. And as we continue through some of our COVID response, and I'll also talk a little bit about some of our previous response that led up to the COVID response that's happening today. Governmental public health in New Jersey in general, of our 21 counties, we have 100 local health agencies within the state. They vary from small municipal, multi-municipal to regional. There are 21 county health departments, including Newark Health Department, that comprise a larger regional public health response in New Jersey called New Jersey Links. And Ocean County Health Department is one of, if not the largest shared service health department in New Jersey and one of the 22 Links agencies. In terms of a quick overview of our agency, we have approximately 225 full-time staff. Typically on an annual basis, so our budget is about $35 million that we just adopted for fiscal year 22. We are a separate autonomous agency from the County of Ocean. However, we do have strong ties. I do have an Ocean County Commissioner Liaison, and my 9-member Board of Health is appointed through the Ocean County Commissioners. And during COVID, we have hired between 400 and 500 seasonal employees to assist with our COVID response from March 2020 to the current time period. From an organizational perspective, I'm here finishing my 28th year, and we've certainly been tested and exercised over the course of my tenure here. I'll highlight some of these, and this is just some of what we've done over the course of time that I think positioned us very well for the COVID response, and this is more so focused on the vaccination side. Back in 2009 with H1N1, we administered over 35,000 vaccinations through our regional pods. During the measles outbreak of 2018 and 19, we stood up MMR vaccination clinics and worked closely with our vaccination partners that are out there. With the COVID response, obviously here we have done countless hundreds and hundreds and hundreds of vaccination clinics, some very large scale of mass vaccination of 2,400 plus in a day, down to what we're doing now, but more of a community-based effort as well. Something else historically that has really positioned us, I think, pretty well back in the 90s and early 2000s, we had a very strong seasonal flu vaccination campaign where we administered between 40 and 45,000 seasonal flu shots at over 100 vaccination sites in a 5-month time period. So large-scale vaccination clinics is not something that's new to us. It's something that I think we prided ourselves over the course of time, and we took that experience and expertise into the COVID response, as well as many others as well. So going through January to mid-March of 2020, still a lot of unknowns at that point, a wait and watch time period, staff meetings to track progress, watching the vaccination development over the course of that time period as well through 2020, preparing for the worst case scenario with a strong confidence and readiness that we can stand up whatever we need to through the years of collective expertise. And then Friday the 13th in March of 2020 really was that tipping point, I think, where we really kind of dove in full speed and really went full speed ahead with a lot of the COVID response with the cases and contact tracing that led up to the vaccination in December of 2020. As we went through the summer and the fall, vaccine became available throughout the country, throughout the state. We were working closely with all of our other local public health agencies and partners, as well as the state health department. I think it was a gut-wrenching, exhausting year for everybody across the board. But I think we were very excited and ready to start the vaccination side of this. I think it was a renewed effort to be able to hopefully have a new beginning to the end of what we were experiencing for almost the last year. And we did over 100 pre-identified and exercise sites that we could open if we needed to throughout the large geographic region that I described earlier as well. In terms of a quick snapshot of Ocean County healthcare delivery, we have 4 acute care hospitals, 2 that are part of the RWJ Barnabas system and 2 part of the Hackensack Meridian Health. We have 2 federally qualified health centers with multiple sites throughout the county. I mentioned the 2 health departments. You have a network of various urgent care facilities and pharmacies, which I think would play crucial as the COVID vaccination response moved forward. I will say Ocean County did request multiple times to be both a testing site and a vaccination mega site, but we were not selected anywhere along the continuum of the initial vaccination, nor in the fall of 2021, when booster shots were becoming available as well. As we started vaccinating, we received our first vaccine supply, December 23rd, 2020 at approximately 11 a.m. And we were vaccinating less than 24 hours later, Christmas Eve, 2020, 8:30 a.m. we administered our first dose of COVID vaccine. At the height of late December, early January, we were vaccinating about 2,400 people per day at our mass vaccination clinic. Unfortunately, over the course of the next several weeks, going into February, Ocean County did experience a reduction in the vaccine supply to the vaccine shortage that was nationwide and within the state of New Jersey. And today we have administered over 130,000 doses of vaccine at this point, and we continue to have those vaccination clinics to the tune of about 5 per week, even as we sit here in May of 22. Some of the approaches to vaccination as we've kind of moved through the continuum, our approach was a single large mass vaccination clinic that would expand then to a regional-based model, then to a community-based model. Our concern obviously would be within our senior population, the 60 plus, trying to get that access point to them, working with our Ocean County Office of Senior Services to assist them with making appointments for a limited vaccine. Homebound population, we have a very, very large homebound population here within Ocean County. We've administered over 1,000 doses of vaccine within the homes, working with the faith-based community, businesses such as Six Flags Great Adventure and other businesses throughout the county. Also working with different county, municipal government, the schools within Ocean County, the county library system, and really a grassroots effort as we proceed and move forward with this. I can say during the height of this and probably from a June of 2021 up to current, every resident within Ocean County could drive within 2 miles of their home to get vaccinated if they choose for that vaccination. Also, we were part of 11 counties that the state had identified as ambassador counties. We had 5 target municipalities that we work closely with the local partners and officials. We were recruited to meet weekly to discuss strategies and messaging as we move forward with them and trying to increase those vaccination rates, which for the most part were very successful. I think we had a lot of strong support and buy-in from them, which went a long way to assist us as we continue our vaccination efforts. When you're looking back, I think on some of the strengths and successes that we had, I think it's a strong county, Board of Health and municipal support as we move forward. I think it's the robust capacity that's tested over time, proven track record, extremely dedicated, experienced, and qualified staff at the Ocean County Health Department, as well as within our healthcare partners and being very strong partners within our county and very strong long-term relationships with them as well throughout Ocean County. As we kind of look back and we continue to assess some of the challenges, I think some of the inability to craft unique messaging, Ocean County and really all of New Jersey is very heavily influenced by the New York and Philadelphia media. So I think when you're looking at messaging, a lot of the residents here within Ocean County see the messaging that's outside of not only Ocean County, but also outside of New Jersey. And social media, I think in general, where everybody became an expert over the course of time and overnight, and it had an opinion related to vaccination and everything related to COVID as we moved through the last 2 years. I think there was a lack of some consistent higher level risk communication and messaging to be able to provide some of that information. And I think we just need to kind of get back and provide true public health science with some of this, where we have over a year of experience now with vaccination. I think it's crucial to get some of that information and data out as we take some of the next steps and go through the next 7 or 8 months as we finish out 2022. Then also looking at public health officials not being able to lead and tailor some of the response to their local community during a public health emergency. And really the county municipal officials are just as much, if not more accountable to the local constituency as state and federal partners as well. And trying to get that local messaging and crafting that, I think is incredibly crucial as we move ahead for this. So I would leave it probably at that for this point. If anybody has any questions, I'd be more than happy to answer them as we go through the rest of the program here today.
Hello again, this is your host, Dr. Edward Halperin. hoping I can persuade you to give back to NYMC. We provide these webinars at no charge and the CME credit at no charge. But programs like the one you're watching and our research do not come for free. It costs real dollars to put on these programs and very real dollars to conduct laboratory research on COVID-19. We hope that many of you will consider making a tax-deductible gift to offset either the cost of this webinar or to support our research. You can write where you'd like the money to be designated on the subject line of your check or when you call in your donations. Great things are happening in New York Medical College. We hope you'll be a part of it. To make your gift, you can call 914-594-2720, and a friendly member of the development staff will be happy to take your credit card information over the phone. Or for the more techie ones among you, please go to our website, www.nymc.edu/give, and make your donation in that way. And for those aficionados of paper and pen, please make a check out to New York Medical College and mail it to New York Medical College, Office of Development, 40 Sunshine Cottage Road, Valhalla, New York, 10595. Thanks for thinking of us at the college during these challenging times. Stay safe and healthy. And now let's return to our program.
Hi, I'm Dr. Lori Solomon, Chair of Family and Community Medicine and Medical Director of the Family Health Center at New York Medical College. If you're confused about recommendations regarding vaccinations, you're not alone. By the end of this presentation, you should have an understanding of the terminology and timing of vaccinations so that you can answer this question. I have no conflicts of interest to report, sadly. So for the primary series, the current recommendations are for the mRNA vaccines, which consist of 2 shots. The first is Pfizer, or it's also called Comirnaty. It's 2 doses, 3 weeks apart, and that's available for anyone who's age 5 and older. The other one is Moderna, or it's called Spikevax, and that's 2 doses, 4 weeks apart, and that's available currently for anyone who's 18 and older. The Janssen or the J&J vaccine is a viral vector vaccine, and is no longer considered a first-line recommended vaccine due to its lower efficacy and the greater chances for forming blood clots. So what's the 3rd dose? Some people have conditions that weaken the immune system, and they will not get an adequate response to 2 doses of the mRNA vaccine. They need 3 doses to get to the same level of protection as those with normal immune systems. So people who are currently receiving treatment for cancer, those people who have received organ transplantation or CAR T-cell therapy or stem cell transplant in the last 2 years, people with advanced or untreated HIV, those with immune deficiency syndromes, or those people taking high-dose steroids or other immune suppressing medications. Now that's different than a booster dose. A booster dose is a vaccine that's given after the body has already made a response to the vaccine, to a primary vaccination series. And so right now, COVID boosters are the same vaccine that's given as the primary series. So for Pfizer, it's actually the same exact shot. For Moderna, it's actually half of a dose of the shots that were given for the primary series. Booster doses just remind the immune system about the infection. It increases the antibodies that are circulating in the blood and our immune response. Other common booster doses that you might know and have probably received are things like tetanus. So same shot, just separated in time from your original vaccine series. So anyone who's 12 and above is eligible for their first booster dose. And so for 12 to 17, the only booster dose that's available is Pfizer. If you're 18 and above, you can have either Pfizer or Moderna. And there's some data now that says if you've got your primary series with one, you may get a little bit better effect if you switch to the other one for your booster dose. If you have a normal immune system, you're eligible for your first booster dose 5 months after you've completed your primary series. So 5 months after you've got that second dose of the mRNA vaccine. If you're immune compromised, You're eligible for your first booster dose 3 months after you've completed your primary series. And if you got the Janssen or the J&J vaccine, you're actually eligible for your booster dose 2 months later. Those who are eligible for booster dose number 2 is actually 3 groups of people. So if you're age 50 and above, you're eligible, or if you're 12 and above and have an immune compromising condition. And then also those people who receive 2 doses of the Janssen or J&J vaccine are eligible for booster dose number 2. And you are eligible for booster dose number 2 if you received your last COVID shot more than 4 months ago. A little confusing with the timing. They keep changing the months. So the question is, should you get your booster dose if you're eligible? Well, that's not as straightforward as everything else as the eligibility criteria. So some of the things you might want to consider when you're thinking about whether or not you should get your booster dose now is, are you or your household members at risk for getting severe COVID? So think about their vaccination status. So are you living or are you around people who are unvaccinated, either because they're unwilling or because they're unable based on age? What are their health conditions, or what are your health conditions? If anyone who's immune compromised is at higher risk for having severe COVID. And then the greater your age, or the greater the age of the people you're living with, the greater their chances are for having severe COVID. So you might want to consider that. And then also, how likely are you to get COVID? So think about, are you traveling? If you're traveling frequently, that puts you at higher risk. What is your occupational exposure? Are you at a greater risk based on what you're doing? How often are you going to large gatherings, especially if they're indoors and you're not wearing a mask? So if you've got a bunch of indoor gatherings coming up in the next couple of months, maybe you should get your booster dose now. And then you may also want to think about the levels of infection in the community. So if there are high levels of infection currently, that may be a reason for you to get your booster dose now. Should you wait a while? Well, if you have had COVID recently, you may want to wait a while. We know that the people who've had COVID within 90 days are less likely to get reinfected. The chances aren't 0, but you are much less likely. Having a recent COVID infection is kind of like having a natural booster. And then you may also consider, what current mitigation strategies are you using? Are you social distancing? Are you wearing your mask? Are you avoiding indoor gatherings? And if the answers are yes, you could probably wait a while. And then you may also want to consider your tolerance for vaccinations. And so if you're the type of person that wants to get one vaccine and doesn't want to get anything for quite some time, you may want to wait until later on. We do know that both Moderna and Pfizer are currently working on reformulating their vaccines to include Omicron-specific variants, and that reformulated vaccine is likely to be available in the fall. So if you don't want to get an extra, another vaccine after this one, you may want to wait until the fall until you can get an Omicron-specific vaccination. So here's a handy online tool that the CDC put together if you're still confused about whether you're up to date with your COVID vaccine. You just put in your information and it will tell you whether you're up to date. And that's the website if you're interested. Anyone who would like a COVID vaccine can come into the Family Health Center. We have both Moderna and the adult and pediatric formulations of Pfizer vaccine available. Thank you all for listening.
Hello again, this is your host, Dr. Edward Halperin, here to tell you about some of our academic programs in New York Medical College that might interest you. As we've been doing these webinars over the last 2.5 years or so, people have sent us emails or written in the Q&A box that they might be interested in learning a good deal more about public health or biomedical ethics, insofar as we've touched on these topics during the webinars. Some people are interested in a career in these disciplines, getting a certificate of competency, or just taking some courses. Well, if that would interest you or a family member, here are 2 web addresses you can use to learn more about our course offerings in the Master and Doctor of Public Health program. And in the Master's in Biomedical Ethics program, some people don't want a degree, they just want to take a few courses either online or in person. All are welcome. Use these website addresses for the public health program and the medical ethics program as we show here. You might want to take a screenshot, get out your cell phone and photograph it, or write these web addresses down. Remember, throughout our program today, if you have questions for our panelists, write those questions in our Q&A box and we'll get to as many of them as possible. And now let's return to our program.
Hello, everyone. My name is Michael Liu, and today I'll be presenting on the presentation as shown, essentially how the supply chain for drugs can be improved upon and what have the pandemic taught us in regards to that. I do not have any relevant conflict of interest to disclose. The first question is, what is supply chain management? And essentially, in summary, is the interdependent steps to create value. The value equation, which is shown on the bullet here, is the perceived benefit divided by costs. Now, while perceived benefit is primarily driven by marketing, again, why are you using this laptop? Why did you perhaps enroll in this college? The supply chain really optimizes on improving costs by reducing it as much as possible. And therefore, it opts to target streamlining operation workflow. That is really the key of supply chain management. And in supply chain management, or SCM, the goal is to translate all these input and to produce an output that is viable product or service, such as this laptop I'm using right now. However, in order to be successful in SCM, you need to have a system consideration, because any step that's broken in the chain can cause significant decrease in output or even a complete halt in the output. Here you can see the SCM process. If we go through a clockwise motion, starting at the bottom left-hand corner of raw materials, again, your goal is to get that raw material all the way to the customer at the bottom right-hand corner. And you can see multiple steps are involved. All right, well, that's SCM overview. Now let's focus on the topic at hand. How about drug shortages? If we look from this bar graph from January 2001 all the way to March 2022, the y-axis shows you any new shortages identified during the year. The x-axis or horizontal axis shows you the years involved. You can see that in 2020, while there were significant new shortages, the pandemic really didn't cause any significant new shortages from happening. In fact, as the pandemic rolled on, new shortages actually decreased. However, just because there's no new shortages doesn't necessarily mean there were no SCM problems. So in 2021, you can see that the reasons for the national drug shortages in the United States are shown here in this pie graph. And the top three reasons is 42% unknown, as highlighted in the blue, followed by supply and demand, 27% in red, and manufacturing in green at 22%. For the remainder of the presentation, we're going to focus on the supply and demand and manufacturing issues. Here, as far as drug manufacturing, it breaks down the percentage of active product ingredient, or API, manufacturing of where does it come from in the United States. You can see that most of the API that's manufactured across the entire world for the United States, 28% happens right here in the US, followed by 26% in the European Union, and then India and China at 18 and 13% respectively. Therefore, if there's any significant impact in any of these big regions, so to speak, let's say in China or India, because of, let's say, geopolitical issues or some sort of economic problem or regulatory issue or even environmental disaster, there will be a significant reduction in the active drug being produced. Again, not new shortages, existing drugs to have. So that is one of the key reasons why there are supply chain issues, is that there's manufacturing issues that can occur because of those reasons. And you can see on the bottom right-hand corner, supply chain, international supply chain of drug manufacturer or any manufacturing could be as simple as sending the home product to the foreign market directly, or if there's multiple regulatory involvement, which can happen with political or economic issues between the countries, additional layers may be added, including an exporter regulation, importer regulation, so on and so forth. So the chain can get relatively complicated depending on how free the trade is between countries. Another issue, now this is specific to pharmaceuticals, is disasters that happen. The y-axis shows you the estimated cost of the shock. The x-axis shows you the estimated foreseeability. The darker color represents more frequent occurrence, while the lighter the blue shade, the less frequent the occurrence is. Now, the most common occurrence that we see even pre-pandemic and even during the pandemic is theft, counterfeits, cyber attacks. While these are not necessarily foreseeable, they can happen all of a sudden, the cost of the shock is relatively low. The infrastructure in the US and also the security measures can allow us to address these very promptly. However, when you have a pandemic, such as what's highlighted here, while you could foresee it ahead of time, it can cause significant cost of shock to the manufacturing. And when you have the significant cost on top of manufacturing demands, which I'll go over in a second with supply and demand issues, it becomes quite a bit of a problem to produce the drug to get to the consumers. So while pandemic is foreseeable, it can have significant economic costs. The other issue is supply and demand. And we use the toilet paper as an example, even though it could be related to drugs or any other commodity. You can see that, let's say there's an increased demand for toilet paper. Well, there is under-ordering, but then also because of this increase in demand, the retailers say, oh, we got to get more. Then they pass it to the manufacturer, hey, we need more from you guys. And ultimately, the supplier needs to bring in more. But the problem when you also manufacture a lot more is that the amount of toilet paper consumers asking doesn't necessarily mean they actually need that because the rate of usage is still the same. So when there's a over demand and all these chains produce more, what happens is the transfer of the cost to the consumer goes up. So now the cost of toilet paper goes up or the cost of the drug goes up, manufacturing goes up. But then ultimately when you overproduce, the demand will go down. And ultimately now you have extra supplies that you have to reduce the cost to make up for it. So essentially economically, it doesn't benefit the consumer. It doesn't benefit the manufacturers or the retailers or the supplier. Overall, this can cause a significant problem in supply and demand and manufacturing and availability of drugs. All right, so enough bad news. How do we combat these two issues, supply and demand and manufacturing? First is contingency planning. So for example, here you can see the different COVID variant on the y-axis from alpha all the way down to Omicron. On the right-hand side, I show you the susceptibility of monoclonal antibodies. You can see that majority of them were effective against most variant up until the Omicron variant. Therefore, it's always worthwhile to not just carry one type of drug, but perhaps carry a primary drug and then alternative drugs in the event you face supply chain issues with one manufacturing. This is analogous to, let's say you have a laptop and then you have a spare laptop or spare phone in case your internet goes down. Always have a contingency plan whenever possible. And this actually happened with COVID-related examples here at Touro University. We actually, for example, used this Buy Next Now initially. However, because of supply chain issue, we had to resort to other manufacturers, which we were able to plan very successfully to prevent shortage from happening. Strategy number 2 is projections. So this is a map of Connecticut during the COVID pandemic. You can see that as time goes on, there might be a seasonality pattern. During the summer, there's relatively low COVID screening. However, as we head to the winter months, there's significant more in demand in COVID screening. Spring, it starts waning down, and by the summer of 2021, barely any screening, and then the pattern repeats itself. So while COVID doesn't necessarily have a season component guarantee 100% of the time, there is some seasonality component to it, which helps you project demand. So right now, we are thinking of how much do we need for the winter potentially in terms of COVID screening. And we saw, again, this pattern in Touro University, Touro, New York. You can see that during the winter month, there's a spike in specimens collected. However, as we head to the spring and summer and fall, there was low demand for COVID screening. And then it repeats itself for the winter of 2021. Now, there is a word of caution in some of these two contingency planning. Projection errors can happen, and also market equilibrium. The picture on the left shows you Y2K when the year 2000 happened. A lot of people thought the world was going to end. Obviously, that didn't happen because otherwise I wouldn't be here right now. And you see that this individual stock up a hand sanitizer during the beginning of the pandemic, expecting people to have a large demand for it. Unfortunately, this hoarding did not work well for this individual, and in fact, it did not result in him making the amount of cash he thought he would. And last but not least, on the bottom right-hand corner, show you a market equilibrium example. This is using inflation from the 1775 all the way through 2015 as an example. You can see like a roller coaster, there's peaks and troughs, equilibrium, peaks and trough, equilibrium, so on and so forth. So the bottom line is, whenever you see a big increase in supply or great demand for supply, it could swing back the other way relatively. It's just a question of when it will happen. So again, you can see multiple factors affecting some of these issues that we face with COVID-19 drug supplies. And thank you for attending my presentation, and I'll address any questions you guys may have.
Hello again, this is your host, Dr. Edward Halperin, hoping I can persuade you to give back to NYMC. We provide these webinars at no charge and the CME credit at no charge. But programs like the one you're watching and our research do not come for free. It costs real dollars to put on these programs and very real dollars to conduct laboratory research on COVID-19. We hope that many of you will consider making a tax-deductible gift to offset either the cost of this webinar or to support our research. You can write where you'd like the money to be designated on the subject line of your check or when you call in your donations. Great things are happening in New York Medical College. We hope you'll be a part of it. To make your gift, you can call 914-594-2720, and a friendly member of the development staff will be happy to take your credit card information over the phone. Or for the more techie ones among you, please go to our website, www.nymc.edu/give, and make your donation in that way. And for those aficionados of paper and pen, please make a check out to New York Medical College and mail it to New York Medical College, Office of Development, 40 Sunshine Cottage Road, Valhalla, New York, 10595. Thanks for thinking of us at the college during these challenging times. Stay safe and healthy. And now let's return to our program.
Now we turn to summer fun, cruises, summer camps, theme parks. I'm Dr. Robert Amler, and I have no conflicts to disclose. Once again this summer, we want to have fun, and we wonder if this virus will get in our way. Well, here are the COVID trends, United States, since way back in January 2020, when we did this first webinar. You can see that in the recent weeks leading up to this month, we have had an increase in daily reported cases. There has also been some increase in daily deaths, but we'll see that again in just a minute. Now, here and now in Westchester, just this past week, we've seen a likewise increase of, you'll see about 363 cases each day, compared to more than 4,000 cases, new cases, at the peak last January, with a positivity rate between 9 and 13.5%. That's a lot of new cases. But the reality is you are so much safer if you are vaxxed and boosted. Look at cases on the left, deaths on the right. Let's note that cases and deaths have had recent spikes. These data only go till December, but we know what we're looking at. We're looking at Omicron. And yet in both cases, the big spikes are from the unvaccinated, unboosted. When you look at those dotted lines toward the bottom, especially the bottom right when we're looking at deaths, look at the arrow. People who were vaxxed and boosted had very, very low rates of death, 53 times less likely to die if they were vaxxed and boosted compared with the unvaccinated population. So COVID today is not as bad, but it is still here, and the strategy has not changed. Avoid exposure to prevent infection. Vaccinate to protect from disease. Test if symptoms occur. Avoid exposing others by isolating. So as we think ahead about summer fun, it's obvious that our summer destination settings will determine some of the transmission scenarios, and they will be different depending on where we choose to go. Summer camps, which will be open this year, have mostly outdoor activities, minimal crowding. Most of the campers and staff are vaxxed and or boosted. Masks are normally optional. And if campers or staff are sick, they stay home and test. And any unvaccinated people at the camp are sent home at that time. For sleepaway camps, make sure you've got a good understanding about medical care if your camper gets sick and what happens if they have to go home. Cruises are booking this year. Most of the passengers and staff, again, will be vaxxed and probably boosted. There will be crowding indoors, even though outdoors activities do occur and they're better, and masks are normally optional, but that crowding indoors introduces another level of risk. And when you're on a cruise ship, you can't go home if you're sick, too far to swim to shore. So positive cases that occur on board are likely to be cohorted or isolated so they don't spread infection to the others. But there is a level of risk on a cruise ship. Theme parks or national parks are another scenario, and parks are opening this year. Remember that parks attract guests from locations all over the world who may come from areas with much higher rates of COVID infection. There will be crowding at these parks, even when you're outdoors, as people line up to get into various attractions. And of course, there are large numbers of young children, some of whom cannot yet be vaccinated. Will these folks stay out of the park if they're sick? Well, that's really going to be up to them for the most part. And so transmission at these parks seems like it is likely to happen in some cases. So wherever you think of going, consider safety. Think if any adult or child in your group is not up to date on vaccine and boosters, if they're at increased risk for severe illness, if they're unable to physically distance, if they are caring for sick patients, if they're at a job where they interact with many unmasked people, if they are often traveling or congregating with crowds. So before you book, consider your own situation, the value of your trip, the risk of transmission, and before and during the trip, what happens if someone gets sick, and what about all the many unforeseen issues that might come up along the way. Consider also if you can cancel or postpone a trip at the last minute, and if you must do that, will you carry trip cancellation insurance, and will you read the fine print to make sure that you really will have adequate coverage from that insurance if and when you need to cancel the trip. Either way, I hope you have a healthy summer, get vaccinated, and have fun. Thank you.
Hello, this is Edward Halpern, your host, with another review of how to get your continuing medical education credit. Text the code 94EARL, E-A-R-L, in capitals, to 828-295-1144, and you'll get a response back that will have you do the CME questionnaire and get your credits, or go to www.eeds.com, click the sign in button, enter the same code, and the same process will ensue. Or get that cell phone out or the iPad and scan that QR code, and it'll start vibrating and it will walk you through the process for the questionnaire and for your CME credit. Please take a screenshot, write these numbers down, get your cell phone out and take a picture so you can remember to get your credit, because all of these options will expire by May 23rd, Monday at noon. We hope you've been enjoying today's webinar. We hope you've been typing your questions into the question and answer box. Now it's time for the question and answer portion of our program, and your host for the Q&A part of the program is the president of Touro University, Dr. Alan Kadish. Dr. Kadish, the floor is yours.
Thank you very much, Dr. Halpern. Another very interesting series of talks, and we've had a lot of interest from the audience in asking questions. So we'll start with Dr. Sherleta Amler. And it's actually a bit of a personal question, Dr. Amler. It's you talked about how the fact that you love your job, but isn't it true that throughout the country, a lot of people working in public health have been under intense pressure, have felt burned out? What do you see about the effects of the pandemic on the future of the public health workforce?
Thank you for that question.
Sure.
I think during the pandemic, no matter what job or profession you're in, there's been a lot of burnout experienced by people. But I think in public health, the advantage we have is that what we do is so varied that it does tend to keep our interests a little bit more. I've had people who've retired, but I've had an awful lot of young people who've got degrees in public health or in a science and are interested in public health, who've recently signed on to work at the Westchester County Department of Health. And these people are young and energetic. And I think for them, the pandemic has fueled their interest in a career in public health. So I think public health is still as strong as ever. And I'm grateful that we have such a young workforce interested in a profession that I love very much. So thank you for that question.
That's great. So one more question for you. If a person's only gotten one dose of the vaccine, is there a risk that this sort of partial immunity will help propagate mutant strains of the virus? Or people who have, in general, if people have incomplete immunity, is there a chance that they're somehow pushing mutant strains?
I think that's a very interesting question. Obviously, it doesn't matter if you have one dose or are fully vaccinated. If you develop COVID, there's always a risk that a genetic modification, alteration, mutation could occur, and any individual that you then spread the COVID to, that variant could be propagated. That's how we got Omicron and the other variants that we've dealt with. So it is an ongoing issue. And certainly that if someone is fully vaccinated, they have less chance of getting COVID and less chance of spreading COVID, whether it's the current strain or a variant, to others. And so that's one of the reasons it's so very, very important that people get vaccinated, that they get their boosters, and that if unfortunately they do get sick, that they stay home and try not to expose others. Thank you for that question.
No problem. So I think we'll stick with the public health theme for a few moments and get Dr. Regne on as well. Dr. Regne could join us. Hi, good to see you.
Hello, how are you?
Good. So the first question for you is, COVID-19 is not the only RNA encapsulated virus. Have you had to deal with other RNA encapsulated viruses, or is this a brand new class of infection agents?
Well, I think from the perspective with the COVID-19, I think it's something new for all of us. I'm not a virologist or a clinician. So from that perspective, we deal with a lot of viruses, and the messaging that we put out there is to best respond to and mitigate any threats to the communities that we serve, whether it's pharmaceutical or non-pharmaceutical with that.
Great. Second question is, you mentioned that there are different communities with different demographics within your county. some where there are older residents who are retired, and some where there are, such as Lakewood, where there's a heavy weighting towards young people. So the question here is the way you deal with public health in those two different kinds of communities different, or is it simply one approach that works well for both of those kinds of communities?
Yeah, and that's a great question. I think every service area that we have, every jurisdiction, everybody on this call covers is unique in many ways. Ocean County is not any different from that. The uniqueness with Ocean County, with the size, if you think of Ocean County, if you're aware of it from the northern part of Lakewood and Brick and Jackson, Lakewood is more of your urban area. We have a heavy Orthodox Jewish population. It requires a very specific public health approach to be able to work with that community versus the southern part of Tuckerton, which is a lot more rural. You have our barrier islands of Seaside Heights, and further up you have your Manalogans and the farmlands of New Egypt and Plumstead. The approach is very, very different. That's where I think when part of my presentation is kind of the one size does not fit all. That's not even just for Ocean County compared to other counties. That's Ocean County within Ocean County. We are where north meets south, and it's kind of like the northern part is more of a New York influence and the southern part is more of a Philadelphia influence. We have a lot of senior communities, religious communities, migrant populations, and the approach is very, very different. And we have to approach all of that. And we have partners in the community to be able to best mitigate and address all of those public health concerns, because there's many of them outside of COVID as well. But that's a great question, and I appreciate that.
Sure. Have you seen a difference in cooperation and when you work with faith communities to try to deal with that? Give us an example of how you've done that and perhaps what's worked and what hasn't.
That's a great question as well. And really working with the faith community and also the business communities and after actions from H1N1, when you're looking at your clinics and looking at the population that you're reaching, and obviously you're not reaching the most at-risk population. So faith-based and working with all the different religions and faith-based entities that are out there, they know their community so well. So that's something that we've really spent a lot of time in working on. Over the course of time, a lot of our vaccination clinics were housed within a faith-based community, whether it's their parish hall or within their synagogue, and we're offering that to all the different constituencies that are out there with that, and they're just such a vital part. And when you're looking at the vaccination component as well, the messaging, if you look at who do you trust in any kind of an emergency related to that, a lot of times it's your priest, it's your pastor, it's your rabbi, that you go to for information. So having them part of that messaging, I think is incredibly important, not only for the actual vaccination of the needle in the arm, but also the messaging and working with them and in partnership with them to get that messaging out from a trusted source of information.
Great, thanks. Sounds like you've done a lot of good work in a tough time. So the last question before you let you go, at least momentarily, is more of a systems question. You described the fact, I believe, that there are more than 100 health departments in New Jersey. One could say the same thing about perhaps police and fire departments, so I don't want to pick on health departments. Do you think that's the best way to organize the system? Should we be doing something a little different and better?
That's a great question. That's a question that's been going on for many, many years. Unfortunately, New Jersey is a home rule state. So that local municipality decides how public health is delivered within their township. If they want a small municipal health department, I think I kind of went through the different types of health departments. If that municipality wants a small municipal, that's what they would set up, and they just need compliance within the state public health practice standards. Many of them are county-based systems, and there's everything in between related to that. Back in 1997, 1998, I think the state recognized that could be problematic, and they developed a regionalized response system within public health called the LINCS, Local Information Network Communication System. And they identified each county and some of the larger cities to be able to respond to public health emergencies in New Jersey. So there is a hybrid version of the 100+ health departments of these larger entities of governmental public health agencies charged with preparing for, exercising, and responding to public health emergencies, and that's housed within a county structure within New Jersey.
All right, then I have one final question, both for you and Dr. Sherleta Amler. So we'll get her back on, and that perhaps, at least nationwide, there's been a big increase in illicit drug use during the COVID pandemic. Have you seen that? How has it complicated what you do, and what do you think the solutions are going forward? So it's a complicated question, but let's start with Dr. Amler, and then we'll come back to you, since give you a little bit of a break.
Sure.
Thank you for that question. Well, the health department in Westchester for probably more than 10 years has been working on overdose related issues. It's been an ongoing problem for us, but certainly the problem has been exacerbated by the pandemic. And one of the things that we have done locally is we have been training both police officers, because they are frequently the first person on the scene when there is an overdose, as well as the general public, to administer Narcan, which is an antidote, so to speak, for opioid overdoses, and which is the most common overdose that we see here in Westchester. In addition to that, we've actually put nalox boxes, which are boxes that contain Narcan, in some of our homeless shelters and other congregate care kind of facilities, so that if an overdose occurs and there's no one immediately around, the person could simply go into the box, get the Narcan from the box, and an alarm goes off to let us know that the box has been opened and it can be administered. Because literally you have just a couple minutes to administer these life-saving drugs if you're going to get the person back. And we have found this has been very, very successful in at least preventing deaths. And then the whole issue of overdoses, we work very closely with our mental health colleagues to try to address substance abuse in general. Thank you for that question.
Dr. Regnick, can you tell us a little bit about your experience with drug, particularly opioid overdoses? And has it gotten worse during COVID, and how are you responding?
Sure, and I think it's been a huge issue and a problem for many years. We're actually making a lot of great progress towards that. And unfortunately, with COVID the last 2.5 years, I think there's many unintended consequences of COVID and the lockdowns and the changes of lifestyles. And I think we have a lot of work ahead of us in the public health world related to this, and certainly with overdoses and working with our medical examiner. I agree with Dr. Amler. I think the law enforcement and the first responder community is key. We actually are integrated into the police academy here in Ocean County for all the new recruits going through. We have an educational series and component related to that. We also have been very active on the Ocean County Fatality Review Task Force, which is a social autopsy of decedents as a result of overdoses. And that's something that we've been doing for the last 7 or 8 years, and continue to work with all the partners. But talking to our medical examiner, we are seeing a huge increase. And that's very unfortunate. And we continue with everything that we've been doing with that, working with our law enforcement and prosecutor and all of our providers, the mental health side of it. But I do think we have a long road ahead of us collectively within public health and the healthcare delivery, dealing with what I'm calling the unintended consequences of COVID that we're going to be seeing for many years, unfortunately.
Great. So we'll take a break from the two of you in the direct public health and move on to a little bit of a different kind of public health with Dr. Robert Amler. So Dr. Amler, good to see you again. So there've been a number of questions about booster doses and fourth doses, particularly for Omicron variants. So I'm going to try to summarize them with the following two questions. First of all, are you convinced that the data show that a fourth dose is effective? And if it is, given that COVID is spiking again, should we suggest that everyone get even a fourth booster dose of the mRNA vaccines? Or do you think the evidence is not quite there yet to have everyone do it and only high-risk groups?
This is a great question, and I thank you for bringing it up. The overall question of whether the vaccines and the boosters in combination have been effective against Omicron has sort of two answers. The first, you can look at the graphs that we looked at, and you can see that cases do continue, and there have been spikes even within a vaccinated population. But the severity of those spikes, the severity of the cases that are represented in those spikes is far, far less among the vaccinated and boosted. It's been difficult to tease out because of the different populations, the different age groups, and the different exposure settings. Hard to tease out how much the additional booster contributes to the overall effect of fewer complications from infection, which is really what we're seeking at this point. Since that's difficult to tease out, I certainly endorse the current recommendation for those groups that should get the fourth dose to get that fourth dose or booster. Some people are electing to wait, and we've heard that discussion in this webinar about possibly waiting a little while. Some people are speculating that there could be another surge this fall, so time your last or most recent dose to be a little bit later so that your immunity will last. I have to say that's really speculation. We don't know what the future will bring. What we do know is that vaccine helps, and more vaccine helps a bit more. How much, I think, is still hard to quantify, but we will eventually get that answer. In the meantime, if you're not sure, talk to your own healthcare provider about the settings in which you work and live, about the exposures you are likely to get, and then people around you, close to you, who might be affected by an acute viral infection. Thanks for the question.
Sure. So now we have some more direct clinical questions that have come in. So I wanted to address those to you. And if others want to jump in a couple of moments, that would be okay too. So first simple question, what advice do you have if I get invited to a wedding, in addition to buying a present? What would I do? Should I go? Should I not go? Should I go and be careful? What do you think about, based on where Omicron is today, what would you suggest?
Thanks for the question. It's a familiar one because I would say over the last 6 months, I've had that question addressed to me in person almost every day. Sometimes we get 1 or 2 days off, but everybody is asking this question. What should I do? This wedding has been planned. It's my loved one, my niece, my daughter, my granddaughter, and so forth, my grandson, my nephew, and so forth. We want to go to weddings. We want to go to family parties and gatherings. And by themselves, they're wonderful things. We do need to consider a few things, and there is no right or wrong answer across the board. But strictly speaking, we need to think about the fact that the virus is still out there. It can still cause damage, although not as much if you're vaccinated and in most cases boosted as well. And you can sometimes take some measures, such as reducing the amount of time you spend in close congregated areas, wearing a mask if you're concerned, finding out if the event is going to be restricted to people who are vaccinated and boosted. And so these are many factors. But again, think about your own personal situation. Are you at elevated risk yourself? Are you older, or do you have underlying conditions? Or do you just worry more? Do you travel a lot? And this is going to interfere with your ability to do that. If you do get COVID, you're going to have to isolate. You may end up traveling and then you get COVID and then you have trouble getting back home because you can't fly. So these things do come up. The other question is, are you in close contact on a regular basis with people around you who could suffer greatly if they get COVID? Think about these things. Give us a call. We'll always talk to you. We don't give medical advice, but your health provider can. And you can also talk to us in public health, and we can talk about the risk factors. Thanks for the question.
Sure. The next few questions are for Dr. Solomon. You could join us. Thanks, Dr. Solomon. So the next question is about long haulers or long COVID. Can you briefly summarize, are you seeing cases? What do you think about the entity? And how concerned should we be about it?
I've seen some case. Thank you very much for the question. Interesting question, and I have seen some cases of people with with long haul COVID, as it's being called. I have to say I've seen a lot of people with COVID and very few people with the long haul COVID symptoms. So I think that at least in my experience, it's a very small number of people for as many people who have been infected. Do we know everything about long haul COVID? Absolutely not. There's a lot of ongoing work that's being done to figure out what is the cause of it, and what we can do to help treat people and support them as they get through it. Looks like we're going to need a multi-pronged approach because it affects people differently. And so a lot of it is trying to get people supported and get them through this as they rehabilitate after a COVID infection.
Thank you. So the next question is actually, I'd like to hear both your perspective and Dr. Liu's perspective about this. It's got to do with antiviral therapy. In the questioner specifically addressed Paxlovid. And so I guess before we get to the details of the questions of Paxlovid, are you currently, for symptomatic patients who let's just say need treatment, are you currently recommending Paxlovid or immunoglobulin therapy or both? What's your feeling about that, Dr. Solomon? Which of those are you recommending?
So I'm seeing, I am seeing quite a few COVID cases recently, and so I have prescribed Paxlovid. I think that the immune therapy it's just hard. It's just less accessible. You have to go to a special place. It's an infusion therapy. Paxlovid is an oral therapy. It's 5 days of medication. There are side effects from it, but it does seem to be somewhat helpful in decreasing the severity of symptoms and the duration. It does come with some side effects like GI upset and some bad taste in the mouth. But
So,
I haven't found any problems with my patients actually accessing Paxlovid.
great. So follow-up question, now that we've talked about the kinds of therapy that are available, and I assume you agree that Paxlovid is the most effective agent that we have currently. Is that a fair assessment?
It's certainly it's effective, and it's the easiest in terms of access. You just have to go to a pharmacy. You don't have to get an infusion.
Okay, so let's talk a little bit about whom you're treating. And let's start with Dr. Liu, and then we'll come back to you, Dr. Solomon. Would you recommend people who have mild symptoms, who are vaccinated, or people at very high risk with no symptoms? Do you think the current recommendations support the use of Paxlovid in those cases? Or what would you suggest the criteria for using it would be?
Sure, President Kadish. So, it is there is some provider discretion. I'm sure Dr. Solomon will agree with me. If I were to sum it up, the current IDSA recommendation, which is best practice guideline recommendation, say that for those who have COVID symptoms, mild or moderate, mild being mild symptoms, but the oxygen status above 94%, moderate means less than 94%, but still not necessarily oxygen therapy, that you may get Paxlovid. It does have a conditional recommendation and low evidence of certainty. Long story short, the reason why is because the study that the guideline is based off of is based on those that are unvaccinated with the lesser variant. So in essence, for those in mild to moderate, there is discretion on whether to use the drug or not. My mantra is, if you necessitate a medical visit and your O2 status less than 94%, in order to prevent hospitalization, those patients should get Paxlovid.
Dr. Solomon, tell us a little bit about what criteria you're using.
I actually agree with what was just said, but I think that for mild symptoms, what I usually do is I enter into a discussion with the patient about what they want out of the therapy, and we talk about the risk versus the benefits, because there are side effects from the medication. It also depends on how long they've been symptomatic, because as you get further from the onset of symptoms, the efficacy goes down. And then, I think that you also still have to realize that people who are unvaccinated are at such higher risk. So those are the people that I would be much more,
Aggressive.
I think I would be more strongly encouraging Paxlovid.
Okay, let's shift away from the patient-specific questions for a moment. Dr. Liu, let's talk a little bit about the supply chain issues that you addressed. And there are two related questions, and they both sort of, I think, come down to the same question is, do we need a national effort to produce more essential pharmaceuticals and baby formula domestically to avoid disruptions to the global supply chain similar that we've seen in COVID?
President Kadish, I think that's a great question. As far as, building a stronger supply chain, yes, we should rely on some internal sourcing. However, as we have seen, during this pandemic, we do need international cooperation. For example, obviously international trade with supply chain, it is great economically. It also creates a lot of interdependence, which means that we have to either cooperate or even co-op, petition, right? Compete yet cooperate at the same time. One of the biggest issues with creating insourcing is that you cannot insource every drug ingredient. So for example, a lot of the active ingredient as well as the inactive ingredient comes from animals, plants that are located in certain geographic regions, marine sourcing, mineral sourcing. So in essence, we should definitely have some in-sources. However, it's very difficult to in-source all the minerals needed because we simply don't have it here in the United States per se. Thanks for the question.
Sure. What about what's happened in Puerto Rico in terms of natural disasters, and should we create more incentives to get some of the manufacturing done specifically in Puerto Rico, where also they may have access to different flora more easily? What's your feeling about that?
Yeah, ideally, like you mentioned, we should build relationship as much as possible, or at least as close to home as possible. If you, in that presentation I gave, the y-axis shows you economic shock, the x-axis shows you foreseeability. Natural disaster kind of ranks in the middle, in between that, in terms of the shock and foreseeability to the drug manufacturing. The reason why is manufacturers often have storage centers located in safer areas. Is analogous to Amazon having their own fulfillment center in certain regions of the United States. So drug manufacturers have that too. And what happened is during natural disaster, even though there's an increase in demand, they usually have enough inventory at base, so to speak, to handle such shock. It's kind of like if you were to fly on an airplane, they foresee a tornado or hurricane coming. Yes, it will affect you for a few days, but then you should be able to get back on your feet. But in essence, yes, we should build relationship as close as possible to home. We should focus on building our infrastructure and not just manufacturing, but even our distribution channel as much as possible. But again, ideally, we should have that cooperation with countries beyond. Thank you.
Thanks. A great answer. Dr. Robert Amler, our last question is yours. So, are you willing to make some sort of prediction about how you see COVID and its variants moving this summer? Should we be concerned that there's going to be another huge peak? Do you think that the public health measures and vaccination we've put in place will prevent that, or is it just too early to know as people are trying to make plans for the summer?
Thank you for that question. You asked me this at the last webinar, and the answer again is all of the above. You can't really speculate on a bug that you don't know enough about, a population that travels freely, and open societies in which there's a great mixing of peoples, really all around the world. There are so many forces, like on a chessboard, that you really cannot predict. However, we know some of the principles. We know that the vaccines we do have are safe and effective. We know that the death and severe hospitalization emergency of 2 years ago and even part of 1 year ago, that aspect has passed, at least for now. For this to reemerge right now does not seem likely, but we still don't know the future. It does seem logical, but only logical, you can't predict, that as the colder months come back in the fall and there's more indoor activity, that like many coronaviruses, you're going to see another surge of cases, hopefully not more morbidity or significant morbidity from those cases, but you really don't know. Will we eventually have to give a vaccine every year like we recommend for influenza? Certainly possible, but right now we really can't predict. The answer is continue to monitor the situation, keep attending these webinars, and stay tuned because we still need to watch what this virus is going to do next and the effectiveness of our response to it. And thanks for the question.
Sure. So I want to thank the audience for joining us today, as well as for some excellent questions. And as you just heard from Dr. Amler, unfortunately, we will probably be back over the summer with yet our next webinar. Join us then and stay safe.